Greetings and welcome to Lobes and Robes, How Neuroscience Can Change the World. This podcast is sponsored by the American University Center for Neuroscience and Behavior and explores the links between neuroscience and key policy questions today. I'm Susan Carl, a professor of law at American University Washington College of Law, and I will help lead discussions throughout our series along with Dr. Terry Davidson, Director of the Center for Neuroscience and Behavior at American University and a distinguished professor of neuroscience here. This podcast is for anyone interested in how scientific discovery can make the world a better place. Thanks for listening.
Our guest today is Dr. Randy Seeley, who is the Henry King Ranson Endowed Professor of Surgery at the University of Michigan School of Medicine, where he also serves as the director of the Michigan Nutrition Obesity Research Center. Prior to joining the faculty at Michigan in 2014, Dr. Seeley was professor of medicine and held the Donald C. Harrison Endowed Chair at the University of Cincinnati College of Medicine, where he also served as a director of the Cincinnati Diabetes and Obesity Center. Dr. Seeley's scientific work has focused on understanding how various peripheral hormones and peptides act in the central nervous system to regulate food intake and body weight, and on developing new treatment strategies for both obesity and diabetes. His research interests include identifying the mechanisms that underlie the effects of bariatric surgery on body weight and metabolism. His expertise also extends to the new class of anti-obesity drugs, such as Ozempic and Wegovy, that have been receiving a great deal of attention for their ability to promote weight loss. Dr. Seeley has published over 370 peer-reviewed articles, many of which have appeared in the top scientific journals in his field. He has earned numerous prestigious awards for his research achievements, including the Lilly Achievement Award from the Obesity Society, the Ernest Oppenheimer Award from the Endocrine Society, and the Outstanding Scientific Achievement Award from the American Diabetes Association. Dr. Seeley's expertise is sought after by many of the largest medical device, pharmaceutical, and biotech companies that are at the forefront of bringing new therapies for obesity and diabetes to patients. I've been very lucky to have known Dr. Seeley for many years, and we are extremely pleased to have Dr. Seeley as our guest on the Lobes and Ropes podcast.
Thank you for having me, Terry.
It's our pleasure, Randy. Okay, Randy, one of the things I guess we'd like you to do is just tell us a little bit about yourself in addition to what I've just mentioned. I know some of your current research interests and maybe a little bit about what you think the status of the field is at the moment.
Yeah, thank you for having me. It's really a pleasure to be here. It's been an interesting ride over this 30 years of my career. I think when I started, there was not much appreciation in the medical community at large, right? That obesity is a biological problem that probably has best thought of with biological treatments. And I think part of that change is our better understanding of how the system is regulated and the key players in how it's regulated. So the identification of a hormone called leptin, I think in particular galvanized the ability for scientists to begin digging in and understanding how it is our bodies regulate our food intake and our body weight. And that has made it possible to begin to bring new therapies to individuals with obesity.
So there have been a lot of starts and stops, haven't there, Randy, in terms of obesity has been one of those kinds of disorders that have been really resistant to analysis. Is there anything new have we broken out of that one step forward, two steps back?
Yeah, I think what you see over the course of my 30-year career, right, is that the belief that therapies could be brought and approved by the FDA and actually reach patients has come and gone. So right after the discovery of leptin, there was a surge of activity from many major pharmaceutical companies and small startups. And much of that went away over the early 2000s and into the 2010s. So it's been back and forth, right, in terms of companies' belief that they could do this. And part of it has been that even when things got approved, that they did not sell very well. And that was an interesting revelation because we all know that there's a great demand, right? There are growing numbers of individuals, right, with weights that are above what is healthy. And most of them struggle to be able to lose weight on their own. And the question becomes, so why didn't the approved drugs sell? And the answer is because their efficacy was relatively low. You could expect somewhere between 5 and 7% weight loss on many of these drugs before. we've entered a new era over the last 5 years with drugs that can produce between 15 and now all the way up to 22% weight loss on average in individuals with obesity. That has meant that both the scientific field has gotten a lot more attention from the public, and the investment community is much more willing to put capital deployed to try to come up with these therapies, because it's clear that, in fact, that the market is now there, right? Before, it was unclear whether there was a market, right, for obesity therapies. Now there is, and that level of assurity, right, has meant a lot more investment in both understanding how it is that body weight is regulated and what new therapies might be developed in order to be able to help individuals lose weight.
That sounds great. And it seems like there's even a problem with supply, that there's more demand than supply at this point for these new drugs. But I'm wondering, before we get into the new drugs, maybe we could start with bariatric surgery and your work there, which I guess is also a more traditional approach. What have you studied in that area?
So what my lab tries to do is to take things that we know already work, there are already good data for in humans, and try to reverse engineer them into better things. So bariatric surgery is a really good example. Bariatric surgery involves the surgical rearrangement of the GI tract in a variety of different forms. And even today, it is still the most effective therapy that we have to bring to patients. And that's both therapy for treating obesity, but also treating type 2 diabetes. So in terms of being able to produce the biggest bang for your buck, right, bariatric surgery can still do that. But obviously, it's not scalable, right? In America today, right, there's about 200,000 bariatric surgeries a year. That is an incredibly small proportion of the individuals who qualify for bariatric surgery. That is, have a high enough BMI or other comorbidities that would make it so that insurance companies would pay for the surgery. So we're doing this for a tiny slice of the population. And it's because we don't have enough surgeons, we don't have enough surgery tables, right, to treat everybody, even if we thought that was the right choice. So my job, right, is to help understand why bariatric surgery works so that we can reverse engineer it into something that is more scalable and effective.
Why does it work?
Yeah, so this is the right question, right? So why does it work? So when I started this particular line of research now 16 years ago, if you talk to a bariatric surgeon about why it worked, they would tell you about restriction and malabsorption. Restriction is the idea that these surgeries create a smaller pouch for your stomach, right, and less room for the food that you consume. And the idea being that we are making it difficult for you to get more calories into the system. They also sometimes talk about malabsorption, the idea that we're changing the intestinal function in a way to make it harder to absorb calories. Now, I can tell you, like, the history of this for me is when I heard people say that, it made no sense to me. Our bodies aren't that dumb, to be honest, right? That we can trick the body into believing that they've eaten calories that they haven't, or that we can sneak calories out of your body without you noticing. It flies in the face, right, of what we know in terms of how body weight is regulated. And it's regulated because we can monitor how much fuel we have in our body. Most of that is in the form of adipose tissue. And as we monitor that, when it starts to go away, your body responds, right? Like many other homeostatic systems, there is a defended level of weight that the system sees as appropriate, a defended level of fuel. And when that fuel drops below that level, it responds. And that response is something that all of us know about, right? Which is that we get hungrier, right? Food in our environment becomes more attractive. We're going to work and seek out food because we're hungrier. And that makes sense, right? For the body's perspective. We don't want to let you sit there and starve to death. Rather, we're going to make you get up and go hunting for food. And when people are just trying to lose weight by just reducing their caloric intake, that's the system that they're fighting. So again, the idea that we could make your stomach small or sneak these calories out when you weren't looking and that system wouldn't respond always seemed weird to me. So the right way to think about bariatric surgery is not as a mechanical intervention, right? That we're making your stomach small, but rather that it's a physiological change to the way that your GI tract communicates to the rest of your body, including your brain, to your liver, to your pancreas, all of these other organs that are involved in how we determine how much we eat and also how we regulate the levels of fuels like glucose. So once you think of it as not a mechanical, right, but a physiological response, well, then now we can start identifying the key things that are changing. How does the body know, right, that we have altered the GI tract in this way? And so what my lab has done, right, is to try to identify the critical players that change after bariatric surgery and figure out which ones of them are most important and therefore, again, might be amenable to other approaches that are not as drastic as the permanent rearrangement of your GI tract. So I can give you a couple examples of this, right? So one of the things that we know, right, is that when you're trying to absorb calories, particularly fat calories, you make bile acids, right? So they are made in the liver and stored in your gallbladder. And when you eat fat, they are pushed out into your intestine as part of how you break down lipids. What's interesting about that, right, is that these bile acids are not just there as a way to break down lipids. It turns out they are hormones. They are signaling molecules. That is, there are receptors for these bile acids. And what we noticed was that after bariatric surgery, the circulating levels of bile acids were elevated, both in mice and rats, but also in humans in a weight-independent way. That is, it's not just because you lost weight, right? It is something that we're changing about the way the GI tract functions that results in this increase in circulating levels of bile acids. So bile acids can act on receptors. If you knock out that receptor, that is, we engineer a mouse that doesn't have the receptor for bile acids, it turns out that bariatric surgery doesn't work. That is, animals don't lose weight and they don't improve their diabetes. So bile acids are a necessary component, right, of why it is that bariatric surgery works. So that's an example.
Yeah, so it's not just the restriction of how much you can put into your stomach.
No, right? Because in these mice, right, we made the stomach exactly as small in the animals that were genetically engineered as the normal animals, right? So just having a small stomach isn't enough to get you to lose weight, right? You have to have signaling through these bile acid receptors in order to be able to have the benefits of bariatric surgery.
I'm wondering, does that mean then that people who've had the surgery just naturally want to eat less? It's not that they are so uncomfortable if they eat too much that they learn not to. It really is sort of more of an adjustment that feels okay for the people who've undergone the surgery?
That's exactly right. So what's amazing about bariatric surgery, and it turns out it's true about the latest pharmacotherapies as well, is that people lose weight and they're less hungry while it happens, right? If I took you and I wired your jaw shut, you'd lose weight, but you'd be hungry while it happens, right? Again, the magic here, right, is that we have got people to reduce their intake and they're less hungry while they're losing the weight. And that shows you that what really has happened here, right, is that we've changed the set point. We've changed what the body sees as the appropriate weight. And so now you're not fighting your biology, right? You're not fighting your body to go from one weight to a lower weight. In fact, what your body sees now, that's the appropriate weight, right? So as you're doing it, you're working with your body to get there rather than fighting your body in terms of losing that weight.
So Randy, you mentioned magic. I'm going to come back to that when we talk a little bit more about the new anti-obesity drugs. However, I want to ask a question. You could take a longer term view of the effectiveness of bariatric surgeries. And when these things first started, I had this concern that, as you said, we're restructuring the gastrointestinal tract. Aren't there going to be long-term consequences or adverse consequences when these people get older? And I'm wondering, have there been?
So it's interesting that you asked that question because I think we're going to have the same conversation when we get to the pharmacotherapy as well. But obviously, in the case of pharmacotherapy, we can stop the drug if we choose, right? If it's having an adverse effect, we can stop. Bariatric surgery, there is no easy way to reverse bariatric surgery. Right? Most of the surgeries we've done, again, are considered absolutely permanent changes to your anatomy. So we can't undo it, right, if there's a problem. And that does create, again, part of the reason why we couldn't deploy it for everybody, even if we thought it was a reasonable choice, right? It's not just availability, it's just that we'd be creating a permanent change for everybody, right? And that may not be appropriate. So what we do know about after bariatric surgery, right, it's a surgical procedure, which means that it entails some upfront risk, right, of infections and leaks and things that will create problems. But when you look at the long-term data for bariatric surgery, people live longer as a function of bariatric surgery, right? So when you compare it to groups of individuals, right, who didn't have surgery but had the same BMI, individuals who had surgery live longer lives. And it's interesting when you look at the data in detail. So some of that is decreased cardiovascular disease, which is sort of expected, right? Because obviously obesity is a major risk factor for heart disease. But a big chunk of it is actually reduced levels of cancers, right? So again, that goes to the fact that we're changing the biology of the system and the physiology of the system in a way that actually creates a longer life and a healthier life. And that extends to reduced rates of cancer. And we don't really know how that occurs, but it's super clear in the data, right, that occurs. So we know that there's real upside benefit to having bariatric surgery. And probably not all of that benefit is encompassed with the weight loss, but at least a large amount of it is encompassed with the weight loss.
That's fascinating. I had no idea. I'm wondering, what about the comparison between persons who have had bariatric surgery and people of normal BMI? Are the people with bariatric surgery outliving even those who don't have obesity or type 2 diabetes problems?
So the studies aren't really done in that way because it's hard to find what the real comparator group should be. So it's hard to match along all of those. What we know, right, is that compared to no intervention, individuals with obesity, right, who get bariatric surgery end up living longer than the control group. Do they live a normal length life? Well, again, that you get into lots of issues about how you'd make that comparison, and it's very hard to draw a firm conclusion whether you have gotten rid of all of the issues associated with their obesity, or maybe even improved them in terms of living even longer than they would have without intervention. It's super hard to know exactly whether that's true or not.
So, Randy, there are some people who have weight regain, and I don't know what the percentages would be, but they've had bariatric surgery and end up sometimes regaining weight. One question is, how many people like that? And when that happens, is it that, how should I say, they become resistant to these changes in bile, or those changes are no longer occurring in those folks?
It's absolutely true, right, that some individuals will regain weight. How many people do this depends on what you would call an unacceptable weight regain. Where do you draw the line? It's about 20% that don't achieve a 20% weight loss or more when you look at about 3 years out. There are two issues for any individual, right, about what their weight regain looks like. So the problem is that we don't have a control group for you, right? Meaning, I don't know what the natural history of your weight would have been. Meaning, just as an example, right, most women, when they go through menopause, will gain some weight. We don't believe that bariatric surgery, right, is going to prevent that biological change, right, in your hormone levels that lead to a different and increased body weight. So if we had a perfect control group for you, right, we can compare to how much weight you would have gained without the surgery, right? But we don't have that for everybody. So we do have these randomized trials where we can see what a group of people would do. But anytime we're talking about an individual, you don't know what they would have been. And I think one of the important things to know about bariatric surgery too, right? Very few people achieve a normal BMI. Right? And when we use normal, right, a BMI of less than 25.
That's interesting.
Right?
Yeah.
Almost all of those individuals, right, will still have a higher BMI than, again, what we would consider healthy. Again, these are arbitrary, right, what we call healthy and not. But very few people make it to that arbitrary line. And at some level, that's sort of proof of what I've been trying to tell you, right? Like, this is about the biology, right? If this was just about restriction, you would expect that there would be some people who would lose too much weight, because we made your stomach too small, right? And that you couldn't fit enough calories in there in order to maintain a healthy weight. That never happens. It is very rare for people to lose too much weight after bariatric surgery. And again, when women who've had bariatric surgery become pregnant, there tends to be weight gain during pregnancy. Those women who've had bariatric surgery gain normal amounts of weight during pregnancy, right? So again, the system is still operating in a normal way. And that makes it complicated to be able to say exactly, to predict for any one individual where they're going to be, because most people aren't thinking this way, right? That, by the way, over my next 20 years of life, I'm likely to gain another 40 pounds. Well, nobody wants to think about that being true, even if on average it might be true, right? So we all want to look in, where were we before surgery versus where we are after? But again, that may not be the appropriate comparison to ask whether, in fact, surgery had a benefit.
One more question about that. I'm wondering, I find it fascinating that the surgery also helps with type 2 diabetes. Does it cure? Do people actually resolve their diabetes, or does it just make the situation better for them?
So for a good proportion of individuals, you will get what is termed remission. And again, we don't talk about cure, remission, right? Diabetes, like obesity, is a chronic disease that requires a chronic treatment. What bariatric surgery does is just provides that chronic treatment that you only had to go to the doctor once, but the treatment is going on, right? Your altered GI tract is going to continue changing your physiology, right, for the rest of your life. But what you see, right, is that people will get in remission. That is, they can have a normal blood sugar, a normal HbA1c, which is a measure of the long-term blood sugar, And many achieve it without any coming off the drugs they were on. Now, what turns out to be true here, though, is the worse your diabetes is, the less likely you will get to full remission. The older you are when you get surgery, the less likely you are to get to full remission. So almost everybody's diabetes gets better, but only a subset of people will actually show remission. And also, again, diabetes is a degenerative disease in some way, right? It keeps getting worse over time. And that process doesn't end when you get bariatric surgery. So many individuals who show remission early on after surgery in the first 3 to 5 years, at year 10 or year 15, again, they will fall back into the category of being an individual with type 2 diabetes that requires additional treatment, including pharmacological treatment.
It's very controversial and been in the news, these bariatric surgeries that are performed on minors. And I'm wondering if you have any data on that or any thoughts on the appropriateness of that.
Yeah, so the trials that have been done primarily in teenagers ages 16 and above. And what you see out of those trials, right, is that those individuals, right, we're talking about individuals with severe obesity and already, even at age 16, clear other comorbidities, cardiovascular disease or type 2 diabetes. So these are individuals who are at great risk, right, over the course of their life to develop serious conditions, right, that require lots of ongoing treatments. What you see is that the earlier we intervene, the better response we actually get. They lose more weight and see more improvements in their comorbidities. And when you now look at those patients 5 years out, they are much better than your prediction about what those patients would look like. Again, given the fact that many of them already had type 2 diabetes at age 16. We think of this as a disease that people get when they're older. And again, as the obesity epidemic has gotten worse, the onset for type 2 diabetes has gotten earlier and earlier. So for these individuals, again, it turns out that when you look at them 5 years down the road, they are much better off than they were before. So it's not a trivial thing, right? It's not a trivial decision to make to, again, permanently rearrange somebody's anatomy when they're 16, 17, 18 years old. But what is clear is the earlier we can intervene in the disease process, the less damage obesity does. So it's a chronic drag on the operations of lots of your body, right, to have elevated body weight. And the earlier we can treat it, the less damage it's had a chance to do to the system. So that's not an answer, right? Like in the sense like, should everybody get it or should everybody not? Because it's complicated, right? Those are difficult decisions for healthcare providers, and it's difficult decisions for these teenagers and their parents, right, to make.
So, Randy, let's extend that to the new class of anti-obesity drugs, the Ozempic, Wegovy, Mountjaro, and so on. I'm going to ask you about how these things work, but following up on what you just talked about in terms of early exposure to bariatric surgeries, early exposure to these drugs, should these drugs be used, say, as preventative for obesity?
It's an interesting question. There are a couple levels to this kind of question, right? So one is just sort of the biological piece of it. But that's not the only piece of this, right? There's a issue of societal choices and costs that are associated with these things.
There are some people doing it already, probably.
Exactly, right? Again, whether that's a, right? Yeah. And let's put it this way. For people who can afford it, that's probably already happening, right? And again, these drugs are not inexpensive by any stretch of the imagination. And so there's a lot of societal questions about what's appropriate and how we should make them available and how we should deploy them in order to produce the most benefit. But right now, we don't do that. We don't make any logical top-down choices about how we do this, right? It happens in a very haphazard manner about who gets access to these drugs and who doesn't. The National Academy of Pediatrics came out with new guidelines for deploying these drugs in young teenagers and teenagers that have extant obesity, right? So kids with obesity, right, that meet certain criteria, right, the guidelines now say they should be considered for making these drugs available, right, for their use. Again, we do not have really large trials of what those kids will happen, again, 10 years down the road by their exposure to these drugs. We have better data actually for bariatric surgery around this. But my general view, right, is that what we've learned from bariatric surgery, right, is that treating earlier is probably better. And given that the track record of these drugs on the whole, right, has been that they are safe, it probably is worth considering deploying them more aggressively than we are today. Does that mean every kid who meets a certain BMI criteria, right, should get these drugs? Probably not. But should we be considering it more actively than we are today? Again, here's the thing that is hard to get people completely to understand. Doing nothing is not a risk-free option. So if you're an individual with obesity, that obesity increases your risk for lots of different disorders and on the whole, right, hurts their quality of life. So the question becomes, doing nothing, and to say like what most interventions look like, right, fall under what I will term loosely as we're going to tell you to eat less and move more as a way to try to treat your obesity. Those are mostly ineffective. There are individuals for which appropriate counseling and behavioral intervention will have a benefit. And we want to make sure that those people get that benefit. But for the majority of individuals, right, their increased body weight is a function of their biology, a function of their body defending that increased body weight, and that merely telling people and giving them tools to try to eat less and move more to create weight loss is ineffective. People will lose weight and they will regain it. They will lose that 50 pounds and regain it multiple times over the course of their life. And the question is, how many times does that have to happen before we decide to intervene and use the biology that we understand now to help them, to make it easier to lose weight consistent with their body rather than fighting it?
Can I ask about, so there's this phenomenon now and where every celebrity you've heard of seems to be using these drugs. I know people who use the drugs who are far from obese. Does the calculation change where this practice is extended far beyond sort of the category of people who are identified as having these really serious health risks because of their weight? What do you think about that?
So it seems very obvious, right, from a medical perspective, right? If you don't have those risks, the drug cannot benefit you by reducing those risks. So when you now do the risk-benefit ratio, right, there is a risk of taking these drugs of an adverse event. And if you're getting very little medical benefit from those drugs, then the risk-benefit ratio is not nearly as positive as it is if, in fact, you have other components of disease states, right, that are made worse by your weight. So it's about a risk-benefit analysis, right? And when you're going to get less benefit from the drug, that makes the risk look larger than they would be for an individual, right? That is, doing nothing has less cost, has less risk associated with just doing nothing. So in that situation, right, you're going to benefit less from these drugs considerably.
These are people who think, as autonomous individuals making decisions about their own lives, that the benefits, whether they be psychological, social, whatever, that the benefits outweigh the obvious fact that there may be risks. And so they're making these decisions, maybe getting the drugs off label or ordering them from Canada. I know somebody who gets her drugs from Canada. Is that something that we should be concerned about as a public health matter, or are the drugs kind of probably safe enough that it doesn't need to be a big concern?
So if you're talking about if they get the actual drug, right? Let's just talk about that scenario first, right? They're not getting something that is tainted in some way. If they get the actual drug, the overall risk of the use of these drugs is relatively low. And I think one of the things that's hard to get people to understand, right, is that this class of drugs that we're talking about, GLP-1 agonists, has been around for 15 years. We've only started using it for individuals with obesity in the last several years. We've only had wide adoption for use in individuals with obesity over the last several years. But it's been used in individuals with type 2 diabetes for 15 years. So we have millions of patient years of experience with these drugs that point to the fact that on the whole, they provide real benefit and reduce risk. So even in individuals with just obesity and not type 2 diabetes, it's a 20% reduction in cardiovascular disease events. So if you already have cardiovascular disease, we put you in this trial and we compare to a control group, and the folks who are 20% less likely to get strokes or heart attacks if they've been taking the drug, right? So again, real concrete data, right, that shows net benefit.
Can I ask you a question about that? Is that reduction because of something positive the drug is doing, or is it because with lower weight, your chances of a stroke or heart attack are lower?
So it's a wonderful question that you're asking. The answer is complicated. So we know, right, that there's a net benefit to losing weight for your diabetes, for your cardiovascular disease, all sorts of other things, kidney disease, all sorts of stuff, right? Trying to decide whether that weight loss was the only thing that drove the benefit in humans turns out to be very hard. Because the problem is you have to have a control group. And that control group would be somebody who lost weight but didn't take the drugs. It's hard to find that control group, right? It is hard to get people to lose and keep off 20% of their body weight over a 5-year period for a study like that as a comparator. And that just shows you the dilemma that we're in, right? It is very hard to overcome the biology that wants you to be at a particular weight and to simply, by act of force of will, to choose to be a lower weight. I analogize this to imagine if you were trying to hold a life preserver below the water. So again, you're taking this thing that wants to be on top of the water and you shove it below the water. You can do that and you can hold it there below the water as long as you're paying full attention and you're not tired and you're not distracted. I can hold this thing below the water. Good, great, I'm doing it. But as soon as you get tired, that life preserver is going to go right back to the surface. And I think for many individuals, that's what life trying to simply will themselves into losing weight looks like. So they take on whatever diet of the day that they think might help them, and they are going to count their calories, right, and lose weight. And in fact, they can lose weight for a period, but the cost is that they're going to be hungry. And that means that when you talk to individuals who try to lose weight by just force of will, they'll tell you that at 10 o'clock, I start looking at menus for lunch. I'm thinking about where I'm going to go to lunch. I am, at some level, sometimes obsessed with the food and food stimuli that are in our environment. We sometimes call that food noise. And when you talk to individuals who either had bariatric surgery or taken GLP-1 agonists, one of the first things they say about it is, the food noise is gone. I can focus on things. I know that there's a Pizza Hut 3 blocks from here, but I don't think about it all the time. It is a very different relationship they end up having with their food environment, and it's because their body believes that their weight should be lower. So those food stimuli in their environment are not calling to them in the same way. If you're underweight, those food stimuli are highly salient, right? Your choice of what behavior I should engage in from a biological point of view, you should be engaging in behaviors that get you more food, and your body is pushing you to engage in those behaviors. If you're above the weight that your body sees appropriate, then your entire psychology leaves room for the other behaviors that you can engage in, right? You don't need to be pursuing food as the primary goal object.
So, Randy, you're kind of getting into why these drugs work, but I'm not sure if the brain mechanisms that might underlie the notion of changing in set point or food being less attractive, do we know what those mechanisms are and how these GLP-1 agonists, and I probably should mention semaglutide is the powerful form of normal GLP-1s in our body. Do we really understand how they're working in the brain?
So first, we know that they are having direct actions in the brain. And the reason we know that, right, is work that we did where we engineered a mouse that had no GLP-1 receptors in the brain. And when you now give them a GLP-1 agonist like semaglutide, their blood glucose gets better, but they do not reduce their food intake and they do not lose any weight. So it is absolutely necessary to get these drugs into the brain in order to have the weight benefit. And as an interesting aside, the most salient side effect of these drugs is that when you initially take them, many individuals feel nauseous over the early taking of the drug. And that's why we actually titrate the dose, right? So we start at a very low dose and slowly work up over months to the full dose. Because if we gave you the full dose at the beginning, you'd be very nauseous as a function. That effect, right, even though people feel that effect in their GI tract, is actually an effect of the drug directly in the brain. Because when we get rid of those GLP-1 receptors that are in the brain, the animal also tells us that it doesn't feel nauseous in response to it. So all of that benefit, right, is an action of the drug in the brain. And the hard part now is trying to understand, Terry, right, is where in the brain, what parts of the brain are doing this? What's the circuit? And this is where there's been a lot of, I would call it serendipity in the development of these drugs, right? So remember, these drugs were developed for type 2 diabetes because there had been clear benefits, right, in individuals where we infused this hormone, GLP-1, right, a gut hormone that has actions on the pancreas, right, to get you to secrete more insulin. This hormone has a very short half-life, right? Minutes in the plasma. These very strange experiments where they took people and they just infused GLP-1 for 24 hours, they would see that, in fact, that their blood glucose would get better in an individual with type 2 diabetes. That's where all of this starts. All of it starts with companies developing analogs for that hormone to be able to treat type 2 diabetes. then what you see is that some of these individuals are losing large amounts of weight. Lots of basic research then found, again, that this GLP-1 system is also in the brain, right? You don't make GLP-1 only in your gut, you actually make it in your brain. And there are receptors for it all over the brain. And it turns out, again, in rodents, we could put GLP-1 directly in the brain and you'd see reductions in food intake. So now that's, again, where you bridge the gap, right? You use observations to try to get there. Now, the question was, where in the brain is that acting? We're still not clear. There's still a lot of debate between me and my colleagues about exactly where this is happening. And what's interesting about that is we didn't make the drugs to get into the brain. That's what the protein engineers were trying to do. They were just trying to make an analog of this hormone that lasted longer. But lo and behold, it gets into the brain, and it gets in evidently into the right areas of the brain in order to be able to produce this benefit, right? This net benefit of lowering your set point and making your weight loss easier because you're working with your body rather than against it.
So, Randy, you were quoted in the New York Times as saying that these drugs go to unusual places. And I think what you were implying, actually stated in that article, was that they go to places in addition to those that are thought to be involved in the control of energy intake. I study memory mechanisms, and I know there's lots of GLP-1 receptors in the hippocampus for memory. And there's also a lot of GLP-1 receptors in areas of the brain that seem to be involved with nausea. And then obviously there's the rewards areas of the brain, that circuitry. So they're all over the place, and it makes it, I think, as you would say, very difficult, right, to sort that out. Do you have any ideas about how that it could be sorted out? Or do we even have to worry about it?
Well, I mean, I think from a clinical perspective, the drugs work and are on the whole pretty safe. So all of this back and forth, right, is sort of an interesting scientific exercise. But it's also about how would you make the next generation of these drugs? How do you make them better? What we know is that not all GLP-1 agonists can produce the same amount of weight loss. So some are more effective than others, and we don't know why. And so it would be helpful to know exactly where they need to go in order to be able to make them better. So your point is exactly right. There are GLP-1 receptors all over the place in your brain. And what's interesting about these drugs, right, is that they get into the brain, but they only go to some areas and not all of them. So for instance, when you do a labeled version of semaglutide and you give it to an animal and you look to see where in the brain it went, the hippocampus isn't someplace it goes, right? And at some level, you might think that's a good thing, right? That is, we're not willy-nilly turning on all the GLP-1 receptors you have in your brain. That might actually create problems if you did that. But that it's going to the right places. Now, what are the right places? So there are two places in the brain where it's clearly getting in. One is in the brain stem, both in areas that are outside the blood-brain barrier, like the area postrema, but also into other areas that are behind the blood-brain barrier, like the nucleus of the solitary tract. The other place that they get is the hypothalamus. And Terry, you understand this, right? The long debate in the field has been how important is the hypothalamus versus these other brain regions in regulating your weight under normal conditions. And for a very long time, me and many others believe, right, for changes in body weight, changes in long-term energy homeostasis, the hypothalamus was the king, right? That's what mattered the most. But I think we now know, right, that there are brainstem areas, right, that are absolutely important for normal body weight regulation, and that we can tweak them in different ways only in the brainstem and still get benefits in terms of weight loss. So now the question becomes, the debate is, these drugs get into both the hypothalamus and the brainstem, which one's most important? And again, we play this game by engineering mice, right, that lack these GLP-1 receptors in different locations, and now ask, hey, how well does the drug work? And again, it becomes complicated because not all the drugs act in exactly the same way. And I'll just say quickly why this matters. Pfizer and many other companies are trying to develop what we call small molecule versions of these drugs, right? So these drugs are peptides that you have to inject. So patients would love if they could take it as a pill rather than to have to jab themselves with a needle. But when you do that, again, the drug has to get into the brain. And when you have a small molecule, you can make it so that it easily crosses the blood-brain barrier and gets all over your brain. And the question is that a good thing? Getting it into lots of places, will it cause more weight loss because it's hitting all of those places? Or are you going to actually increase the potential for side effects because you're hitting GLP-1 receptors in lots of different locations? And we don't know the answer to that yet. Pfizer recently stopped the development of one of their versions of this, which is an oral GLP-1 agonist, a small molecule that, again, you'd predict gets into lots of places in the brain because of nausea side effects. So those nausea side effects were worse with a small molecule than they are with the peptide. Again, that's only one flavor of this, right? They have other flavors that Pfizer is continuing to develop, and lots of other companies are trying to develop these. But again, it becomes an interesting scientific question about whether this is the right idea or not.
So, Randy, you and I could probably get into the weeds on this and spend a lot of time doing it. I am curious about why you thought semaglutide doesn't impact the hippocampus.
Because it doesn't get there, right? If you label it, I'll say it does not directly activate GLP-1 receptors in the hippocampus. So when you label semaglutide, right, so you can see where it goes and see where it binds, you see...
Are these in obese animals that these have been tested?
Both.
They've been tested?
Both.
Yeah, well, because part of the problem is the blood-brain barrier breaks down in obesity, which means molecules that more normally get in could get in. But again, you and I could probably go into the weeds on this for a long time. And I think it's absolutely interesting.
And crash your podcast numbers to exactly 3.
Yeah,
There'll be 3 people in the world who will listen to you and I argue about this.
Yeah, that's right. I agree with you on that part. It is extremely interesting. I think it's very important to figure this out, especially, again, we're not exactly sure, right, what these long-term effects are. And we want to know what effects are in brain areas that may not be the parts that are influencing body weight.
Correct. And I think the point about that too, right, is what you're certainly doing, right, is you're changing lots about the way the brain is operating, even in places that the drug doesn't touch directly. It's hitting one location, but you're changing the way the brain's operating on a variety of things. So again, just to get down to the idea, right, you are processing food stimuli in your environment differently. When you see a sign for donuts, your response when you're taking these drugs is different than before. So did we change your eyes? No, right? We've changed something about the way your brain is operating in a way that changes what the meaning of those stimuli are, right?
Well, that's all cognitive, right? So we would argue that that's from a cognitive perspective. I know you were going to talk about it from a different point of view, but you could certainly look at it that way.
I think one of the fun conversations you get into here, right, is, well, people are way more complicated than rodents. And so all of this is way different for people than it is for the rodents. And my argument is maybe, but in reality, right, I think is that what people have is the ability to provide and offer way more complicated explanations for their behavior than it is actually that the behaviors are as different as we would like them to be. So the way this operates, right, it's a homeostatic system, right, that seeks to defend a set point is absolutely true. And you can explain lots of people's behavior about this. One of the anecdotes I sometimes tell is like, I always say that cancer researchers have it easy, Terry. Why? Because if you sit down to somebody next to them on a plane and you say, I study how a normal cell becomes a cancer cell, they don't give you their personal hypothesis of the cell cycle. If you tell people that you study food intake, everybody has a personal hypothesis about how this works for them. Everybody has a story about how their aunt lost 58 pounds. It's such an important part of our life. Right? Food is an absolutely critical part of our lives, both from just a biological standpoint, but also a cultural standpoint, an emotional standpoint, right? So much of our lives are wrapped around food and meals and the times we share those meals with others. And so everybody has a thought in their head about how this works. Not always correct, I would say, right? So the fact, again, we can provide lots of explanations for why I gained 5 pounds here and why I lost it there doesn't mean that that's true. It just means that's your view of what you think is happening to you. But again, it turns out we can explain lots of that behavior from this perspective about how you're homeostatically regulating your weight and how you're trading between behaviors when food is most important versus when food is less important.
So, Randy, our time is getting close to being over. Susan, do you have any other questions or comments you want to add?
Well, I think one topic that would be really interesting to discuss, at least briefly, is what the future in this area of research is and what your own future plans might be in terms of the priority issues to research.
Yeah. We're going to have more tools available in the next 4 to 5 years. In the longer term, we're going to have many more tools available. So the future is at least positive in the sense, right, that we're going to be able to put more tools in the hands of physicians to help individuals with obesity. What does that look like? So one of the critical questions here is we have 2 drugs that were approved over the last several years. One is a GLP-1 agonist. The other is a GLP-1 agonist that also is a GIP agonist, another gut hormone. So the same molecule can hit 2 different receptors, and you get more weight loss when you can hit both receptors. Here's the interesting thing about that, right? Lilly has got approval for this drug that's a GLP-1 agonist and a GIP agonist, right? It turns on both receptors. Amgen has a drug that is a GLP-1 agonist combined with a GIP antagonist. And they have excellent clinical data that they can produce large amounts of weight loss doing that. That shows you, again, a little bit about like the conundrum of the science. It's super weird to think that you can get benefit from turning on that receptor or turning it off. Either one works. That's weird from a biologist's point of view. And it just shows you that where this will go is a little less predictable, right? Because again, we're going to find mechanisms that we didn't believe in or didn't understand. Again, so for us, we're trying to understand what those other mechanisms are. Why is it that we can turn on and off the same receptor and still net benefit? Are they the same populations of neurons? Is it the same areas of the brain that we're acting on? How is it different and how is it the same? Is it just because it's producing weight loss doesn't mean that, in fact, that the underlying mechanisms are exactly the same. So the second piece that will happen over time, right, is right now, a major limitation of the use of these drugs is you have to keep taking them. This is like taking blood pressure medication. Nobody expects, right, that if they stop their blood pressure medication, that magically they will have lower blood pressure. That they have learned to be a person without high blood pressure. But individuals all the time believe, right, that once they have lost the weight and they're no longer losing their weight, that they can stop these drugs and keep the weight off. But as we pointed out, right, like if the change in the set point is what helps make it so that you can lose the weight and be less hungry while you do it, when you take the drug away, you would expect people to gain weight. And that's exactly what happens. People are hungry again, they become responsive to food stimuli in their environment, and they gain the weight back. What would be nice is if we could provide interventions where the intervention itself is short, but you get long-lasting benefits. In some ways, that's what bariatric surgery is, right? You get the surgery one time, but it has benefits that go on for years and decades.
Randy, thanks so much for joining us today. I really would like to continue this conversation. And I think what you're doing in the research is really very interesting, outstanding, and has great potential to help a lot of people. So keep up the good work. And again, it's been a very great podcast, and I hope we can do it again sometime.
Great. Again, I really appreciate the opportunity.
Thank you so much. You were so clear. And as the layperson half of this hosting duo, I really just learned so much from hearing you explain all of this. So thank you for giving us your time.
Oh, good. Happy to do it. And again, there's more I can do. You know where to find me.
Well, that's it for this podcast episode. Thanks very much for listening. And as always, we welcome your feedback at neuroscience.policy@american.edu. We hope you'll join us again for our next episode. And do let us know if there's anything in particular you'd like to hear more about.